Monica Arlande. I'm from Team 8, and we're going to talk about what is fibrous dysplasia. So, what is fibrous dysplasia? This disease is an uncommon condition affecting bones in which normal bone tissue is gradually replaced by abnormal and fibrous tissue. This leads to weakened and fragile bones that are susceptible to fractures, pain, and deformities. Fibrous dysplasia is a medical condition that can affect anyone, regardless of their ethnicity, location, and it can be detected at any age. Both males and females are equally prone to this condition, and it's thought that this bone abnormality usually appears during childhood, but it may not be detected unless there are symptoms such as pain, limping, or fracture. Fibrous dysplasia can occur in any bone of the body, but it commonly affects the long bones of the arms, legs, as well as the bones of the face, skull, and ribs.
The cause of fibrous dysplasia happens when a gene changes after conception. It can be detected early in the pregnancy. There is really nothing that a mother can do to prevent this from happening. Unfortunately, the researchers do not know what causes this gene to mutate. However, they have already identified the gene and still continue to study why fibrous dysplasia develops. Because this disease develops from a mutated gene, children do not inherit the gene from their parents and will not pass the disease to their children. There are several factors that the fibrous dysplasia can lead to a number of problems, such as rickets can occur for some instances. Next is if your pelvic and leg bones have already been affected, you may be at a greater risk to develop arthritis. Lastly, if the skull bones are already compromised, your vision or other sensory issues may arise. There are two types of fibrous dysplasia. First, we have the monostotic form, which affects one bone and is active while the child is growing but often becomes inactive after the puberty. It covers about 70 to 80% of fibrous dysplasia. It occurs in the rib, femur, tibia, craniofacial bones, and humerus. The second form we have is the polystotic form. This form, however, affects multiple bones and may remain active throughout a person's life. This covers the remaining 20 to 30% of fibrous dysplasia that can be seen in the femur, tibia, pelvis, ribs, skull and facial bones, upper extremities, lumbar spine, and clavicle. The incidence for fibrous dysplasia accounts for 2.5 to 5% of benign bone lesions. However, the real incidence is still unknown due to the fact that many individuals still remain asymptomatic. The prevalence has been estimated to be 1 in every 5 to 10,000 people. Fibrous dysplasia is most typically identified in children or young adults. There is really no specific gender for this disease. The diagnosis for fibrous dysplasia can be determined using a number of tests such as physical examination, blood test, X-ray examination, and CT scan.
So let us proceed to the symptoms of fibrous dysplasia. So, symptoms of fibrous dysplasia can vary from one person to another. Most affected individuals only have one bone involved, and often there are no associated symptoms, or simply they are asymptomatic. But most of the times, fibrous dysplasia is discovered incidentally when X-rays are performed. And conversely, some affected individuals can have multiple bones affected and develop severe and potentially disabling or disfiguring symptoms. So, in fibrous dysplasia, the areas affected may be described as lesions. So, these lesions can eventually cause affected bones to become abnormally weakened, misshapen, and prone to fracture. So, with that, bone pain can also occur and may be severe. Misshapen of bones or bowing of bones is most common naman in our femur or thigh bone. And due to weak bone structure, fracture can also occur in some patients. So, as specific symptoms associated with fibrous dysplasia depend upon the specific bones involved, let's see how these different parts of our bone affected by fibrous dysplasia. So, any part of our skeleton can potentially be affected. But yung mas common na apektuhan nito ay yung bone sa ating arms and leg, sa ating face or craniofacial area, and also sa ating ribs. So, sa ating leg bone, as what I have said before, when the long bones of the legs are affected, this can lead to frequent fractures due to weight bearing. Additionally, the long bones can eventually become bowed in children. Their legs may not be equal in length, and this can affect the person's ability to walk. In our face or craniofacial region, fibrous dysplasia can include pain and nasal congestion, misaligned or displaced teeth, uneven jaws, and facial asymmetry, in which one side of the face does not match the other side. It can alter the facial features of the person, such as abnormally prominent forehead, bulging eyes, difference in the vertical position of the eyes, so that the eyes are uneven or hindi pantay. But the degree of the facial abnormality vary. Pwedeng mas malala sa iba or pwedeng mas less. And yung shape ng skull naman is pwede siyang ma-altered in certain cases. In our spine, fibrous dysplasia affecting it can cause abnormal curvature, or what we call scoliosis. In our skull, fibrous dysplasia can potentially cause a variety of neurological symptoms. Dahil nagkakos nga ng yung fibrous dysplasia ng abnormal tissue development, it can compress nerve nerves. So, like the compression of optic and auditory nerves in our skull, dahil sa fibrous dysplasia, pwedeng maka-experience yung patients ng vision loss and hearing impairment. Lastly, women with fibrous dysplasia may be at risk of increased pain during pregnancy because of the estrogen receptors found in fibrous dysplasia. Fibrous dysplasia is not really cancerous, but due to malignant transformation and extremely rare cases, this can lead to bone cancer. These malignant tumors develop to individuals who had been radiated for bone pain, or they have a treatment option that has been abandoned.
Proceed with the different treatment options or intervention to treat fibrous dysplasia. So as mentioned earlier, fibrous dysplasia is a rare bone disorder characterized by the abnormal growth of fibrous tissue in place of normal bone. So while there is no cure for fibrous dysplasia, these treatment options or intervention that we will provide and discuss aims to manage symptoms and prevent furthermore complication, and of course to improve the quality of life of the patient. So the treatment options for fibrous dysplasia depend on several factors, including the severity of the condition, the specific bones affected, and the presence of symptoms or complication. So here are some commonly used treatment approaches to treat this disorder. So the first one is observation and monitoring. In mild cases of fibrous dysplasia that are not causing significant symptoms or functional impairment, a watch and learn approach or may be adopted. So ano nga ba tong watch and wait approach? Basically, these are regular monitoring through clinical evaluations, including imaging studies such as yung mga X-ray, CT scan, MRI, and bone density measurement that can help to track the progression of the disease and identify any changes that may require intervention. So after that, we have medication. Medications may be prescribed to manage pain symptoms and reduce bone loss. Bisphosphonates such as pamidronic or zoledronic acid are commonly used to inhibit bone breakdown and promote bone density. After medication, we have surgical interventions. Surgical intervention may be considered in cases of fibrous dysplasia when the condition causes significant pain, bone deformity, fractures, or growth disturbances. The specific surgical procedure for fibrous dysplasia can vary depending on the location and the severity of the disease. Here are some common surgical interventions. The first one is called curettage and bone grafting. This procedure involves removing the abnormal fibrous tissue and replacing it with a bone graft. So yung bone graft can be taken from another part of the patient's body, which is called autograft, or obtained from a bone bank, which is called allograft. So curettage and bone grafting help to restore yung normal bone structure and yung strength ng bone ng pasyente. So after curettage and bone grafting, we have stabilization of fractures. Fibrous dysplasia can weaken the affected bones, increasing the risk of fractures. So surgical interventions may be necessary to stabilize fracture and promote proper healing. So this can involve the use of metal plates, rods, screws, to provide stability and support the bone during the healing process. Then we have pain management. So depending on the severity of pain, over-the-counter pain relievers or prescription medication may be used. Working with a pain specialist can help develop a personalized management plan. So, it is important to note that treatment plans may vary based on individual cases and the specific bones affected. So, therefore, it is crucial or essential to consult with a healthcare professional, such as an orthopedic specialist or an endocrinologist, who can provide an accurate diagnosis and recommend the most appropriate treatment plan or options for fibrous dysplasia patients.
Now we will talk about physical therapy. Physical therapy aims to ease chronic and acute pain, help a person function, move, and live a restored life while focusing on a specific area for treatment. Patients seeking care from physical therapists have experienced pain from various injuries or immobility. This may include recoveries from surgeries, accidents, sports injuries, or birth or growth defects. Physical therapies generally treat non-threatening injuries by assessing and caring for musculoskeletal issues. The problem associated with the muscle can result from strains, injuries, chronic movement issues, or recovery from surgery. So, we have here two types of physical therapy. So, physical therapy has physical exercise and hot and cold therapies. So, for the physical exercise, patients receiving care from physical therapists learn contraction and relaxation exercises to increase mobility. The goal is for the patient to return to pre-injury movement and motion. Most patients can practice the exercises at home between visits and following release from care. While in the hot and cold therapies naman, patient care may include a variety of treatment modalities. This may include ice or cold packs, cryogenics, or nitrogen to lessen chronic and acute conditions. Other treatments may include hot packs, diathermy, and infrared heat to treat chronic conditions and joint pain. Now we will move on to rehabilitation. Rehabilitation is a set of interventions designed to optimize functioning and reduce disability in individuals with health conditions in interaction with their environment. And under rehabilitation, we have here hydrotherapy. Hydrotherapy is used to quicken the recovery of patients following any surgery, which results in decreased movement, decreased strength, and pain. So, the aim of the hydrotherapy following orthopedic surgery are much the same as the aims of a land-based program. It includes decreased pain, increased range of movement, increased strength, improved functionality, encourage correct functional movement patterns, improve balance, and enhance quality of life. So, the advantage of hydrotherapy is it facilitates the early restoration of the function. Depending on personal goals, this could be walking practice or enhanced range of movements within particular joints required for functional tasks. Hydrotherapy is effective as it uses physical principles of water to provide a different and safer environment in which rehabilitation following your surgery can take place. And the next is physiotherapy. Physiotherapy is the treatment of problems of the muscle, joints, or nerves, especially using exercises or by rubbing or moving the affected parts of the body. Physiotherapy uses manual therapy open treatment by using their hands to manipulate, immobilize, and massage body tissues. This method forces improved blood circulation and muscle movement while relaxing the area to relieve pain and stiffness. So, under the physiotherapy, we have here massage. It stimulates the soft tissues to relieve pain, improve circulation, and relax. And joint mobilization and joint manipulation therapies to move a joint in gliding manner to improve motion and function to control pain. And the last one is physiotherapy instrument mobilization or PIM. It is a technique applied with the assistance of handcrafted instruments. That's all for my report. Thank you.
Good day, everyone. For my presentation today, I would like to discuss an interesting case report entitled Monostotic Fibrous Dysplasia of the Mandible in a 9-year-old male patient treated with a conservative surgical treatment, a case report and a 15-year follow-up. Let's take a closer look at the case and the findings presented in the study. Monostotic fibrous dysplasia is a condition where there is an abnormal development of fibrous tissue in one bone rather than affecting multiple bones. So it is important to note that MFD is frequently unilateral, meaning it typically affects only one side of the body compared to polyostotic fibrous dysplasia. This monostotic fibrous dysplasia is significantly more prevalent, occurring approximately 10 times more frequently. Fibrous dysplasia is a rare disorder that usually appears during childhood or adolescence and is caused by a genetic mutation. In this condition, the normal medullary bone is replaced by fibrous connective tissue, which means that the bone develops abnormally due to a change in the genes responsible for bone development. It is important to note that fibrous dysplasia is a benign condition, meaning it is not cancerous. According to the World Health Organization's classification of bone tumors, fibrous dysplasia is classified as a tumor with an undefined neoplastic nature, and this means that while it shares some characteristics with tumors, it doesn't exhibit uncontrolled growth and the potential to become a malignant tumor. In some cases, as written in this case study, the fibrous dysplasia can be linked to hormonal dysregulations. For the patient demographics, the patient in this case is a young boy who is only 9 years old. He was diagnosed with monostotic fibrous dysplasia affecting his mandible, which refers to his lower jawbone. The patient reported swelling and mild facial asymmetry in the left side of his mandible. The swelling had been gradually increasing over the past year, but notably, the patient didn't experience any pain associated with the swelling. And on the examination, the swelling served as a prominent visual indicator of the condition. For his diagnosis, during the intraoral examination, several findings were noted. First, there was an expansion of the buccal cortical plate, which refers to the outer layer of bone on the cheek side. Additionally, the absence of the first decidus molar, a primary tooth, was observed. Moving on to the panoramic radiograph, it revealed some significant features. First, there was a loss of trabecular structure, which refers to the interconnecting bone beams. Additionally, a radiopaque lesion with a characteristic frosted glass appearance was observed on the left side of the mandible. This lesion encompassed the dental germ of the permanent second premolar, indicating its involvement. To further confirm the diagnosis, the cone beam computed tomography or the CBCT was performed, and the images validated the findings from the previous examinations. It confirmed the expansion and thinning of the buccal bone cortex, which is the outer layer of bone on the cheek side. Furthermore, it showed the displacement of the mandibular canal, the passage for nerves and blood vessels, and the location of the dental germ within the lesion. Based on these findings, a provisional diagnosis of fibrous dysplasia was made. For the treatment and outcomes and additional findings of the study, let's hear from Ms. Arlante.
Now, for this study of a 9-year-old male patient treated with monostotic fibrous dysplasia in his mandible, the chosen treatment was conservative surgical treatment. Conservative management involves using minimally invasive or non-invasive procedures to address the condition while preserving normal bone structure and function. Localized surgical excision of the demineralized bone, followed by an osteoplasty and contour remodeling, is one of the conservative approaches for the treatment of asymmetry. The patient has a dental germ. It was in the middle of the lesion, and the paraaxial images showed the mandibular canal displaced buccally and toward the lower border of the mandible. As the germ needed to be removed, the surgical procedure required to extract the germ, along with the need for an osteoplasty to remove the excess bone and a biopsy to be taken during the procedure. Under locoregional analgesia, conservative surgical excision of the buccal bone was preceded, with extraction of the dental germ and remodeling of the region disturbed by the asymmetry. The patient was advised to consult his pediatrician for further clinical and radiological investigations. The patient was followed up yearly, both clinically and radiologically, with a panoramic radiograph. Then, 10 years later, the patient complained of left mandibular asymmetry. Clinical examination revealed a lingual cortical bone expansion beside the buccal one. After discussing the findings with the patient, a second surgery was decided. So, again, under locoregional analgesia, a wide osteoplasty was performed, and the buccal bone was reshaped until the limit of the mental nerve anteriorly and the position of the mandibular canal apically. No complications were recorded in the follow-up period, and the patient was satisfied with the aesthetic results. Now, for the conclusion. So we can say that by opting for a conservative surgical treatment approach, the study aimed to achieve successful management of monostotic fibrous dysplasia while minimizing the potential risks and complications associated with more extensive surgical interventions. So this approach is especially beneficial in pediatric patients as it prioritizes preserving normal bone growth and development while effectively addressing the condition. Lastly, this study concludes that observation and follow up should be maintained closely. And that's all. Again, we are Team 8, and we thank you for listening.